Hey everybody, welcome to Fertility Fact or Fiction, our show where we bring you the latest and greatest in all things fertility, and then we answer all of your questions live. Thank you for joining us. We have a great show tonight. We have a new article from the ASRM guidelines reviewing how to improve your natural fertility, what things work, what things don't work. Fantastic information set, and we have some new tech to share with you too. So we're going to show you how we run through the whole entire video, and we can now draw on the article. So I'm actually going to go through the article with you kind of line by line. We're going to skip some of the more dreary parts of it all, but we will find a way to make it pretty cool and enjoyable for you guys. So I think that will be a cool thing for you guys to check out. And that way you can see everything that you want to see and learn everything you want to learn. And don't hesitate as we go through the show. If you have questions, just go ahead and ask. So you may see me look down. It's because there's an iPad in front of me I need to draw on, but I will definitely maintain eye contact with everyone as we go through it. So hopefully everybody's had a good week. My heart goes out to all those crazy, not crazy, sorry, to all the people in Waukesha, in the States, where the crazy individual obviously had great harm on his mind. So I hope those families are safe, for the ones that are healing, and my condolences to those who lost their loved ones. Terrible. So hopefully we can all say a prayer for those families out there who are really struggling from that horror. Terrible thing to happen to anybody. They were just trying to do something nice and celebrate Christmas. So why anyone would do that is utterly beyond me. So it was a great week. I've managed to do a lot of those question and answer sessions on Instagram. Tons and tons of feedback, some interesting questions, and some hopefully useful answers for you guys. If you like those answers, throw us a thumbs up. I want to make sure that we should do more of those. And I'll try to do them a little bit more regularly for everyone if that's something that you liked. We'll get on there and we'll do that. And I think we might do a YouTube version of it soon too, where we just group together the YouTube questions and then just put up a video on YouTube where I kind of answer them all at once. So hopefully that'll be of use to you all. Okay, so I am going to start our video. And I'll tell you, Tarek, in a second when we're ready for that. Whoops. Okay. Pull down screen share?
Yeah, just the screen on the top.
Hang on one second. From here?
Yeah.
Yep. That one there. Cool. It says it's mirroring.
Yeah.
You're good?
Mm-hmm.
Okay. So I'm going to flip over to this page and we're going to start. So, so this article is called, you can flip it on and show everybody. So this article is called Optimizing Natural Fertility, a Committee Opinion. And so it is the newest ASRM guideline on all things related to natural fertility. It is, there you go. You can see it there. So pretty interesting article. I'll try and blow it up for you all so you can see it pretty clearly there. This has all the information you would want to see on things related to monitoring and related to your cycle monitoring, testing, how often to have intercourse. They even got into something that we were questioned about, I think it was about 2 years ago, which was which position is it best to have sex in. So pretty cool. So the first thing they looked at was fertility aging. So you'll see this graph come up in just a minute, and I'll run through all of the information there with you. So I'll get that graph. We're going to blow it up just a little bit there. That should look pretty good size. Yeah. So what you guys are seeing and what I'm doing lags a little bit. So you'll see the video kind of expand. So as you can see, this is data from really a long time in human history. They're actually going over hundreds of years. And they looked at different parts of the world and different outcomes. But the gist of this actually still holds true. So if you look at the pregnancy percentages for people that are trying per thousand women, that's the the y-axis, and on the x-axis, it's the age of the female. So when they're quite young, you're in your early 20s, leading up to 27. It's a pretty flat tracing, and you're up in that 40, 50, 55% success rate. So really, a lot of these women are able to get pregnant, they're able to stay pregnant, and they're delivering babies. So reasonably high numbers when they're young. And this is pretty consistent over hundreds of years of human history where they're examining them, because it starts as early as the 1600s and goes all the way up until the 20th century. So pretty interesting stuff that's there, neat to kind of see. Once they get into the early 30s, you're starting to see a leveling off, and then a slight decline begins. And by the time you're getting to 37, you can see that everyone is on a downward tilt. So if you look right here in this region, you'll see that these people are experiencing a little bit of a decrease in the chances of success. And that decrease is pretty tangible because you're now going on that downward slope. By the time you get to 42, you can see that the numbers are even more significant. Now you're down from the original, which was, let's say, an average of 45 or 50%. You're getting down to somewhere around the 15% range, maybe the 20-25% range. And then by the time you get down to, let's say, 45, which is right here, you can see that number right there. I'm trying to draw an arrow for you. Then it's even lower. Now you're really down into the 10% range. You're no longer even in the 15% range. And by the time that you get out to where you're dealing with patients that are in their later 40s, it's going to be very difficult for those patients. They're really looking at anywhere from 0 to, sort of 5%. And that's that last category you can see there. So it really makes a huge difference based on age. Your age can be a very significant factor. And obviously that's a huge, part of what we're looking at. So very, very important data that comes out of there. They did look also at the chances, I'm just going to flip back a page here, of your fertile window in terms of the timing. So if you look over here, you can see that there's information that comes up about the timing of your cycle. So they say that the best definition is about the 5 to 6 days beginning before you ovulate and leading up to the day of ovulation. You probably have a little bit of time around the time of ovulation as well. And so that's what they consider the fertile window. So when they looked at the studies that evaluated when the best time to achieve intercourse was, they said it's definitely right before the ovulation, like in the day before or the day of the ovulation. And as they looked at the various women, they actually did studies to analyze this. So we're going to take a look at those studies. So you can see that down here at the bottom. So if you look at figure 2, which should come up for you more momentarily, if you draw a straight line down, and I'll try and do that with a really thin line here. So this is the peak, and if you go straight down, you're looking almost right before day 14. Sorry for my slightly crooked line there. I'm drawing with my finger. But the reality is that you're looking at about an average of about 9%, 8.5% to 9% of the patients who are having sex just once in the month getting pregnant if they time that roughly just before the timing of the ovulation. So that's a reasonable time frame. You can see that as you go to the right of the graph, your numbers start to decline. And if you go to the left, your numbers start to decline. There's obviously still some opportunity around there. It's a bell-shaped curve, as we say, because there's still going to be some timing where you can achieve intercourse. And there are some people that are achieving intercourse very late in their cycle. those are all going to be women that have irregular periods, because your luteal phase is generally fixed, meaning that the time from your ovulation to your period is almost always roughly 14 days. So women that have a successful pregnancy and they're getting it, having one single active intercourse on day 35, are actually probably either having a very late ovulation or they didn't get pregnant from their husband. So that's a whole other story. But the reality is that that's the case in terms of the math. So it's going to be very close to that 14-day time period. And so the optimal time, if you're on a 28-day cycle, would be day 13, 14. The optimal timing for a single active intercourse, if you're a longer period, would be like 1 day later for each day later that your period normally is. So if you're for example, a 30-day cycle, it's probably going to be day 15 that would be the best time for you. If you're a 32-day cycle, it would probably be somewhere around day 16, 17. So that's kind of how they calculated their numbers and where they got all that information from. That's for a single active intercourse. If you look over on the other side, you can actually see what happened with recurrent episodes of intercourse. And in this graph, they actually broke it down by age. So you can see the tracing in the yellow there that shows that if you're having multiple times of intercourse, and the 0 time is the timing of ovulation. So the more intercourse you have, the better the chances of pregnancy. And obviously it peaked when you had it about 2 days prior to ovulation. So if you continued having sex at that time, you actually had quite a reasonable chance of pregnancy. You're looking at about 55% instead of just that 9% chance with one episode of intercourse. When you look at the group that had the higher age 35 to 39, it's a much, much lower chance. Your chances are almost cut in half just looking at your age. So that's a huge thing to keep in mind too, because this data is age specific, as all things in fertility are. And it's super important to remember, what that number means, because you've got to focus on the fact that at the age of 30, you're going to have one number. At the age of 35, you're going to have another number. When you're over 40, this graph would be even lower. Again, like we showed you in the other lines, you're looking at decreasing chances of success as your age goes up. So that's really, really important. Okay, so then they asked about frequency of intercourse. So you can see in the information that they talk about here that you can continue having intercourse pretty much at any frequency you want. Sperm will remain reasonably stable in terms of its performance and its numbers up to every day. Now, many guys will actually start to decrease their sperm performance if they're going every single day. So they generally recommend every day or every other day. And what we've always recommended based on other studies is every 2 days up until the time of ovulation, and then kind of every day for a few days around ovulation. And that seems to work really well for improving the sperm performance, as well as making sure that you're getting excellent sperm quality. And it doesn't get exhausting, because they keep saying over and over again in this article that you will eventually get exhausted and get sick of each other or stressed by the whole process. And we obviously don't want it to become stressful, because anytime you increase stress, you decrease your success rates, and that's never a good thing. The one thing they do mention, which is really important, is some people think that the concept of saving up the sperm is important. And if you're saving up your sperm, if it's going more than 5 days, there is evidence that says that that decreases your success rates. So you don't want to wait too long, because you're actually decreasing the sperm performance. And certainly if you go more than 10 days, semen parameters actually begin to deteriorate. So we get loads of patients where they tell me they're only having sex once or twice around the time of their ovulation. And the patients that are only having sex once or twice around the time of their ovulation are obviously not having enough sex. So you can see it here. It's very clear that these patients need to have more frequent intercourse because the rest of the time is important as well to improve sperm performance. And there's now data that supports the concept that the semen actually can sort of promote the implantation and the preparation of the uterus for embryo implantation leading up to the actual implantation. So it's not just important to have sex right around the time of ovulation to fertilize the egg. It's actually important to get ejaculate into the uterus or into the vagina at least, and subsequently get some of it into the uterus in order to prepare the uterus for the implantation of the embryo. And we don't know how long that process needs to be, but you can see from the graphs I showed you earlier that that's super important in the sense that you go from that 9% chance or 8.5% chance with one active intercourse all the way up to something as high as a 50% chance when you're having multiple acts of intercourse leading up to it. So the frequency is really, really important. Okay, so then they talk about fertility awareness methods. So I do want to kind of review this stuff with you, right? So they talk about the various approaches to this. So the calendar method is simple. You just calculate the length of your period if you're regular. This only works if you're regular. And you subtract 14 days from what your average period length is. That's roughly when you're ovulating. So around that time, you're going to want your peak fertility. And that's easy to figure out. So your 28-day cycle, your peak fertility is going to be at the time when you are looking at around day 14. If you are a 30-day cycle, it'll be day 16. A 32-day cycle would be day 18. A 26-day cycle would be day 12. So that's a simple way to time things out. When they compared these to apps, where you use those apps to predict your fertile window, only 21% of the apps were actually accurate. So there's, and they mentioned that in this study, they said that very, very few apps were actually able to correctly find the dating or the timing of a woman's cycle. So if you're trying to use an app on your phone to figure things out, don't bother, because it's actually not going to be very helpful for you. The simple math of just knowing the duration of your cycle or keeping track of it on a calendar is actually going to yield you a better chance of success than the apps are, because so many of the apps can actually be incorrect. So that's really important to know. Looking at ovulation predictor kits are very accurate. They can have up to a 7% false positive rate, but generally speaking, they're very accurate and can give you a very good indication. And there's good data that shows that using them will actually improve your chances of success and give you a higher yield than normal. And they specify one article, and I'll just kind of highlight it for you here. I'll use the yellow. So they say right here, the use of ovulation detection devices has been shown in a randomized controlled trial to decrease the time to pregnancy. So you're actually seeing a higher chance of pregnancy if you use the ovulation predictor kits. And that's really critical. So what else is important? Well, they talk about cervical mucus. I am not a fan of cervical mucus checking. And there are other studies that actually say that it is very useless to do cervical mucus studying. I'm not sure why they used it in this particular article, but they do say that it can be predictive. So if you are really trying to go natural, you can try and figure it out. Cervical mucus is basically broken down into different categories. They have a slide on this showing it right here, and I'll blow that up for you. So they talk about dry, which has a very low probability of pregnancy. They talk about slightly moist, which has a slightly higher probability of pregnancy. They talk about damp and sticky, which just starts to eke past like reasonable. And then when you're slippery and clear, then you suddenly see this huge increase. And that's the mucus that's there at the time of ovulation. It should be a lot thinner and clearer. And hopefully that's going to allow the sperm to traverse and get in. The problem with this is that, obviously I don't have cervical mucus, so I'm certainly no expert in cervical mucus, but I mean, how do you tell the difference between slightly moist and slippery and clear? Like, I don't know how anyone can really note that, but I'm sure some of you who have the experience of checking this, if you check it, are relative experts. And so if women out there have done this, I would love to see your feedback. Let us know about what your experience has been with checking your cervical mucus. There are fertility centers that still use this. A lot of the more sort of religious-based fertility centers or faith-based centers will use this. It's really being minimized as a technique in the more modern centers. But if it works for you, I guess it works for you. So that's an option for people too. We don't really use it too much, but it's reasonable. The one thing, again, they mention here in this part of the article is that if you are doing fertility awareness methods, whichever one it is, don't drive yourself nutty, because you don't want to cause stress by constantly monitoring or rechecking. And we get people to buy like 5 different LH kits. Like, you don't need 5 different kits, just use one. So that's really important to monitor. They have this great little blurb on coital practices, which is the next slide or the next page. So they talk about routines. So I'm going to start by saying we've already discussed whether putting your legs up for 20 minutes afterwards makes a difference or not. It does not make a difference. Studies where they've labeled radioactive materials and put them into the, or radio, opaque materials, and put them into the vagina and then done x-rays show that as fast as 15 minutes, you can find sperm. And as fast as 2 minutes, when you're at your peak ovulation time, you can get stuff from the vagina up into the uterus and into the tubes. And so that's a very, very important finding, because as long as you stay still for a few minutes, it doesn't really matter what position you're in, you're likely going to get some sperm in there. Does it make sense to jump up and run for the bathroom, which I know some of you do? No, it obviously doesn't make sense to do that. I know some women are very bothered by the sensation of ejaculate in them, and they want to clean it out as fast as possible. You're definitely going to reduce your chances of success if you're doing that. But in the event that you're willing to lay down for a little bit, it doesn't look like you need more than a few minutes for the sperm to get in. You're certainly not going to harm anything by waiting longer, but you don't need to stay kind of, completely still in the Mrs. Doubtfire position for, an hour afterwards. That's likely not going to be of much significant benefit. They do comment on the fact that the position you have sex in is not really critical. That's probably true, although there aren't any studies on that. Having said that, if you're in a position that's going to lead to the ejaculate spilling out faster, i.e. the woman is on top, that's definitely going to be suboptimal, because you're basically using gravity to help get the ejaculate out of you. And so your chances are probably going to be less. Again, there's no data on that kind of thing. They do talk about orgasm. Hopefully none of the guys are watching tonight. Ladies, unfortunately, orgasm does not necessarily help you get the sperm further into the uterus or help with pregnancy. So it definitely helps with the motion of the sperm getting through the uterus and into the tube, but it doesn't actually help in terms of pregnancy. Again, it's kind of hard to do a study like that, because it's tough to monitor people while they're having sex and having an orgasm. I would never put in an application for funding for that study. I think that would be quite an interesting one to be known for sure. Lubricants is the other part that's down here, and I think that's really important, so I'll kind of blow it up for you. You might want to pull that up. So they do talk about the fact that some water-based lubricants will reduce the sperm motility by 60 to 100% within 60 minutes of being exposed. So that's really important, because for those of you that are using KY, which is a water-based lubricant, it may retard the speed or the motility of the sperm. Obviously, you're not leaving it in there with a ton of KY for an hour, but when they expose sperm to KY, it does have a negative impact. For those of you who are using oils, things like over-the-counter lubricants, olive oil, and even saliva, for those of you that are trying to do it more natural, with even as low as a 6 0.25% concentration can actually decrease sperm motility and speed. But mineral oils don't seem to have that effect. There's something called hydroxyethyl cellulose-based lubricants. They also don't seem to have an impact. A lot of people use coconut oil or grapeseed oil, so those ones are probably okay. So that's a really important thing to mention as well and to keep mind of. One of the final things they go through is diet. So, going through Instagram on a regular basis, we've been doing this for several years. I put up posts all the time. We put up huge amounts of valuable information. We've got a reasonable number of followers. If I go on there and I call myself the fertility diet specialist, I'd probably have triple the amount of followers that we have now. And it's amazing seeing what dietitians and dietologists and nutritionists can achieve on social media, suggesting various diets to people that may or may not help. The truth is, the data on diets is very confusing because there are studies that show a benefit and there are actually studies that show none. So for example, the Nurses' Health study in one part of it said that if they followed a fertility diet, which they said encouraged higher consumption of monosaturated fats, vegetable rather than animal protein sources, low glycemic carbs, high fat dairy, multivitamins, and iron from plants and supplements, that those patients had a much lower chance of having ovulatory dysfunction. And in another diet, they showed a significant improvement in success. And we've reviewed a study on the show that showed that the Mediterranean diet actually did improve your chances when you were going through assisted reproductive technology, IVF to be specific. But then they also reference another part of the same Nurses' Health study that said that it had nothing to do with rates of pregnancy or live birth in women doing ART. They talk about the Mediterranean diet. They talk about a Dutch diet, which I wasn't aware of. That's high intakes of whole grains, monosaturated or polyunsaturated oils, veggies, fruits, meat or meat replacements, and fish. And they say that was associated with higher rates, including the Mediterranean diet, of positive pregnancy tests, ongoing clinical pregnancies, live births, and all of those outcomes following IVF specifically. But then again, they talk about other studies that say, no, they found no association, even when patients were doing IVF or assisted reproductive technologies. So is the diet going to solve your problem? No. I mean, if you have a major fertility problem, your partner's sperm is terrible or whatever the case is, you're not going to solve it with a diet. That's just not rational or reasonable. And we won't see that realistically for patients trying this stuff. Okay, what about your habits? Okay, so my favorite topic, you all know I hate smoking. So if we look at smoking, large meta-analysis, 10,928 women and 19,128 non-smoking women, your risk of being infertile was 60% higher if you were a smoker. And you can see that right here. I will circle that in red for you. So your odds ratio was 1.60 for infertility if you are a smoker. That is an absolutely massive increase in the risk of infertility from smoking. We know for sure that it increases the onset of menopause. It speeds it up. So you're going to go into menopause on average 1 to 4 years earlier, which means you're damaging your eggs, you're damaging your ovarian function. We know that it's got a huge increase in risk of miscarriage, in some studies as high as 400% higher. And so that can occur in both natural pregnancies and assisted reproductive technology pregnancies. For the guys, it's a huge change in sperm density, motility, abnormalities. And so it's also a significant factor there. And there are a lot of different mechanisms by which it plays its role, but we know that it has very significant impacts on sperm DNA fragmentation, therefore can also cause miscarriages even if you're able to get pregnant. Whoops. What about alcohol? So if I scroll up a little bit, they talk about alcohol. They say it's not clearly established. I will respectfully disagree. I think it has been. We've reviewed studies on the show and on Instagram that have demonstrated that. They looked at 7,393 women in Stockholm they said that the risk of infertility was significantly increased with increased alcohol, again, close to 60%. That's if you had 2 drinks per day, and decreased in those that had less than 1 drink per day. So a 64% decrease. There is study from a Danish group that showed that for women that had a small amount of wine, they actually increased their success. But then an Italian study said that there was no such thing. So it's hard to tease it out for alcohol, but we know again that it's very damaging to sperm. Guys that are heavy drinkers have a 50% increase in the chance that their baby will have a cardiac defect, huge impacts on sperm DNA fragmentation. And for women, it looks like the majority of the data is suggesting that you will decrease your chances of success by consumption of alcohol. People ask us all the time about caffeine. There's some good data here on caffeine. If you are consuming more than 5 cups of coffee per day, you are going to see a decrease in your success. It's about a 45% decrease in your chances of getting pregnant. If you are drinking 2 to 3 cups per day, you may increase your risk of miscarriage. So we generally tell people 1 to 2 cups per day leading up to a pregnancy or even in a pregnancy has no impact. If you can avoid it altogether, that's best. Marijuana, we know again that has huge impacts. We have a video on our YouTube channel committed to marijuana impacts on fertility. You should definitely click on that. Make sure you subscribe to our channel and put up some likes there and comments. Any kind of marijuana consumption is a 70% increase in your infertility. Men who smoke marijuana have 29% lower sperm counts. Huge increase in sperm DNA fragmentation. Motility can be affected. Morphology can be affected. You can inhibit sperm hyperactivated motility. You can inhibit the ability of the sperm to actually bind to the egg and enter. That's something called an acrosomal reaction. So there's all sorts of impact from cannabis products. So if you think marijuana is safe, it's not. The last thing they jump into, and the last one I'll talk about tonight, is just environmental exposures. So, you know, we get a lot of people talking about exposures to toxins, environmental things, stuff that's in your makeup, stuff that's in your plastic bottles, and so on. It does not look like any of that stuff is good for you, for sure. It most likely has a very significant negative impact, but the data is still kind of lacking. There's a physician by the name of Dr. Laura Shaheen. I'm sure many of you watch her shows and programs as well. She's very active. She's got a lot on this. In fact, there was a recent post for her, so a shout out for Laura. But the actual data is still kind of hard to tease out, and we're not sure. So overall, important things, and they kind of summarize it here. So time to conception increases with age. For women over 35, you should be seeing a specialist if you're not pregnant within 6 months. Intercourse every 1 to 2 days during the fertile window can help maximize your fecundability. For couples who are unable to have regular frequent intercourse, use the fertility awareness methods and help to time it, and it should decrease your time to pregnancy. So that's your cervical mucus or your calendar or using the LH kit. Smoking, alcohol, drugs should be discouraged, and caffeine use should be limited. A healthy lifestyle and diet should be encouraged for everyone. Make sure you take folic acid supplementation. And finally, all people should be encouraged to avoid the endocrine disruptors that are things like, the plastics and the polybrominated diphenyls and the PCBs and all these other chemicals which are out there in society in various forms and in various products that we're all exposed to. So I hope you guys got some information out of that. I think it was a really phenomenal thing for ASRM to put out, so I was happy to share it all with you. If you have any questions or concerns, or you want to review any of that, give us a shout. We're always happy to help you out. Thank you for joining us for Fertility Fact or Fiction. And we're going to take your questions live. And I can see a bunch of them there. I guess you're going to have to scroll through them. So I can just shut this off now, I guess, right? Mm-hmm. We're all good. All right. Cool. Yeah, we might want to keep it on standby. All right. I'll leave it on then. Sure.
How long should you stay on melatonin after successful FET? Is it safe for pregnancy? I'm taking 1 milligram.
It's safe in pregnancy. You should stay on it for the whole pregnancy. Never change something in pregnancy after you've started it, because it will likely have more detriment to change something in pregnancy than keeping it the same.
Would you rather have 10 frozen eggs of a 37-year-old or 20 fresh eggs from a 40-year-old?
Oh, good question. I like that. 10 frozen from 37 would probably give you somewhere around only a 15% chance of success, maybe even lower. You need at 37 probably somewhere around 25 to 30 eggs just to get one pregnancy. So your chances would be pretty slim. At 40 with 20 fresh eggs, you'd probably have a very high chance of success. So assuming you're going to a good center. So this is where our embryo math video is super helpful. At 40, if you're at a good center, they can probably fertilize, if they're 20 mature eggs, they can probably fertilize all of them, or let's say on the low side, 90%. So you're going to have 18 fertilized. If it's a really good center, they should be able to get around 50 to 60% of them to become blastocysts. An even better center for ours, for example, might be able to get more of them to become blastocysts. So if that's the case, you're probably looking at somewhere, let's say around 10, as high as maybe 12, 13 embryos. At 40, we know that 75% of your embryos will be genetically abnormal. So if you've got 10, in theory, somewhere between 2 to 3, and certainly if you have 11 or 12, you're expecting 2 to 3 to be turning into euploid or genetically normal blastocysts. And if you've got that many normal blastocysts, you have a 95.2% chance of having a live baby. So I would be on team 20 at 40 rather than at team frozen 10 at 37. I hope that answers your question.
What does early blast on day 5 mean? Is it the stage after morula?
Yes, it's the stage after morula, and it just means that you probably still need more time or even a full day going into day 6 for that blast to expand to become a day 6 blast.
I'm taking your advice to do the endo test, but according to your team, is it only possible to book it in Windsor and not GTA?
The Fertility test? The endo test? Is that what it says?
Endo test.
If you're talking about the Fertility endometrial menstrual blood infection test, you can do it anywhere in the world. You don't have to come to us at all. You just contact Fertility, order the kit, collect your menstrual blood, and send it back to them. You don't have to be with us for that.
What about fixed men?
So a guy that's fixed, which means he's had a vasectomy, has two choices. One is to reverse the vasectomy, or two is to aspirate the sperm. Success rates for reversals are highly dependent on the technique that was originally used. And then success with the sperm that you get from that is highly dependent on how long the duration is from the original vasectomy. So if you've had more than 7 years, your chances are going to be drastically reduced. If it's been less than 7 years, you actually have a reasonable chance. And some of those couples, if the woman's perfectly healthy, may actually want to consider using a reversal as their technique, because you may not need any more therapy than that. And it's certainly more cost effective than doing more aggressive treatments. If it's been more than 7 years, you will produce so much antibody to your sperm that even if you have a lot of sperm there, they probably won't work. And so in those cases, you kind of need to do IVF, because we actually have to take the egg, take the sperm, and inject the sperm right into the egg, which is ICSI.
From Instagram.
All right.
What are the main causes of embryos not making it to day 5 blast stage?
Well, it depends. And it depends on who you listen to. It's going to be either the sperm quality, the egg quality, both, or it could be the lab that you're working with. So in most cases, most labs are pretty good these days. So it's usually going to be the sperm quality or the egg quality. I've had this discussion with embryologists. It's actually quite amusing. Some of them will tell you that for the first 3 days, it's the sperm, and then for the next 2 days, it's the egg. And other ones will tell you literally the exact opposite. And they'll say for the first 2 days or first 3 days, it's the egg, and the next 2 days, it's the sperm. In my mind, it makes sense that the early part be more sperm related, because the machinery that helps pull apart the cells as the embryo is rapidly dividing and growing actually comes from the sperm. So if you're not making it to anything past like a day 2 or day 3, it could certainly still be egg quality as well, but you're definitely looking at a sperm component. If it's a problem beyond that stage, it's more likely going to be an egg quality component, because it's now spreading into hundreds of cells. So that's really critical.
Can a couple conceive with 0% morphology sperm? Can XE bypass this issue?
Well, if it's truly zero, ICSI can bypass it, yes. Most people, even when we say it's zero, don't actually have zero, but they may have a very small number, 0.01% or 0.1% or whatever that number may be. It's doubtful out of millions of sperm that any guy has completely zero normal, but it may be very difficult to find the normals. And certainly trying on your own, the World Health Organization has set it at 4% by strict criteria, which involves actually kind of fixing the sperm and then staining them to see if their shape is normal or not, which is not just a quick look under the microscope, which is not accurate.
Okay. I'm about to start my third retrieval.
Okay.
I will be on an antagonist protocol with dual trigger.
Sure.
What does dual trigger do? In the past, I had a 50% fertilization rate and 25% make it to 6-day blast.
So dual trigger will help you get more mature follicles. And there is at least one study that suggests that it'll help you get better quality embryos as well. So we dual trigger everybody, and everybody should be using the dual trigger. There are multiple studies now that show that it's beneficial. So it's going to help you get more mature eggs, probably better rates of fertilization, probably better rates of blastulation as well. So that's why you want to do that. Now, if you only had 50% fertilization and 25% end up as blastocysts, I need to know why. So did they use ICSI? Do you have a sperm problem, an egg problem? Some of that stuff should be dealt with before you start your cycle. So those are the cases where I always want to talk to you first before you start treatment, regardless of where you're working with or who you're working with, because we often will tell you to hit the brakes on your cycle, correct whatever is causing the low fertilization rates first, and then get into your cycle, which can very significantly improve your chances.
What are some things you can do to increase sperm mobility and quality when dealing with male factor infertility, or some suggestions to increase your chance of becoming pregnant with a partner who has male factor infertility?
So frequent sex, so every 1 or 2 days, that's number one. Keep the testicles cool. So no hot tub saunas, jacuzzis. Don't wear anything tight. Make sure that he is taking loads and loads of fertility vitamins. There's another study out for one company called ProFertile, but pretty much all of the various fertility vitamins for guys have potential to help. But ProFertile actually has data that supports it, so that's one of the ones we really like. And I don't make any money for ProFertile or anything like that. We just like the fact that they've got data for it. It's a good product that comes from Austria. And the counterbalance to that is if he's smoking, drinking, or using drugs, he could be taking all the ProFertile in the world and it's useless. So you have to make sure he's living clean. If he's overweight, get his weight down. Make sure he's exercising regularly. All of those things are really critical. Stay away from laptops on your lap. Keep cell phones away from your pockets and your hips and stuff. That can make a difference as well. And aside from that, it's just kind of overall healthy, balanced diet and lifestyle.
Hello, Dr. Victory. I just found out today that our IUI failed, and this was our first medicated cycle. I was told by your staff to stop taking progesterone suppositories today.
Yeah.
And I just went to the bathroom and started bleeding. Is this normal to bleed this quickly?
It certainly can be. Everybody's body is different. So yes, it could be normal for you to be bleeding that quickly.
With the comparison that 1 in 4 pregnancies end in miscarriage, what is the prevalence of diagnosing a genetic concern that causes you to end a pregnancy?
So it's actually 1 in 6 pregnancies that ends in miscarriage. It's 1 in 4 women that have experienced a miscarriage. In terms of the genetics, it depends on your age. So the older a woman gets, the higher the chances that there is a genetic anomaly. So for example, at 30, it's roughly 30%. At 35, it's roughly 50%. At 37, you're probably looking at about 65%. And by the time you're 40, you're in the 75 to 80%. Over 43, it's even higher. So your age is the number one determinant of the genetic normalcy or competency of your eggs and your embryos. So that's a huge, huge factor and something that's critical for you to be aware of. We can't really place a specific percentage number on your embryo per se. Like you can't just look at someone and say, oh, I have a 32 point whatever percent chance that you're going to produce an abnormal embryo. But we do know overall, based on the stats, what we are anticipating for most women. And those are the numbers I gave you. And those are on a slide in our embryo math video. So maybe pop up the embryo math icon there for the folks to watch, because that one should be easy to find. Yeah, so if you're struggling with trying to figure out numbers, embryo math is a great way to take a look at that, and I strongly advise that.
I've read a few women mention that they have been told to take NAC 4 days on and 3 days off. Have you heard of this? Your thoughts?
No, and I don't see any biological reason why you should do that. As a general rule, the human body does not like disruptions or disturbances. It likes uniformity. So when you're taking meds, just take the meds. Don't make it complicated. Stick with just balance. It's good tea.
How much does it cost to freeze a sperm sample, and is that the cost per sample?
So we charge $600 for the 1 year of sperm freezing, processing and freezing. And if you're doing additional samples, I think we just charge $150 for the additional ones.
Quick questions.
If you have questions like that, guys, just call into the office, leave a message. We'll get back to you. We don't need to do those ones on the show.
Okay, here we go.
Yeah.
Hey, Dr. V, timing of intercourse. Does it matter the time of day, morning or evening? Also, any thoughts on the pre-seed lubricant?
Pre-seed lubricant has been shown clinically to help. So it's certainly a reasonable thing to consider. In terms of time of intercourse, morning, day, or night, it actually doesn't make a difference. Whenever the mood strikes you, go for it. That's perfectly fine. There's nothing wrong with having sex in the morning or in the noon or at night. Although noon, you got to have a very accommodating job life.
Good job.
Good job, yeah. But if you can manage a so-called nooner, by all means, go for it. There's nothing wrong with that.
The episode's called The Nooner. How can I prepare my body or uterus for donor eggs? Regarding preparing body uterus for donor eggs, does estrogen and progesterone still play a vital role for success after transfer? And what if it's imbalanced? Will it affect success?
Okay, so how to prepare your body? Healthy diet, lots of vitamins, regular exercise, low stress. That's how you prepare your body. And we will give you all the vitamins and supplements that you need. So things like vitamin D, melatonin, baby aspirin, vitamin C and E can help as well. All of those things can be useful. And the fish oils as well, and then your prenatal vitamin, iron. If your B12 is low, you got to deal with your B12. So all of these things can be really, really important to making sure that you get the right amount for you, and that your body is as healthy as it can be to get prepped for implantation of an embryo. From the standpoint of estrogen and progesterone, you definitely will need progesterone. Not every woman needs estrogen, and we, quite frankly, try to avoid it as much as possible. Some women do, but most women will not need a lot of estrogen, especially if you are using letrozole. Then we desperately try to avoid it or use very, very little. With regards to balance, you don't need to balance your estrogen and progesterone. You need to get an appropriate progesterone level, and you need enough estrogen to thicken your lining. We're never measuring the ratio of the two to one another, and I don't believe anyone has ever done any studies to demonstrate that a specific ratio makes a difference. So that's not a critical element of this.
Hey, Dr. Victory, what are your thoughts on HCG wash? Lubricant injections in embryo glue for our last embryo transfer. We want to give it our best go and don't have any answers to our infertility yet.
HCG is a very reasonable thing, the HCG wash, to do. We do it all the time. There is a good meta-analysis that showed a significant increase in success. Neupogen is a little more questionable. The data is not rock solid, but it can certainly be tried and it's harmless. It's just super expensive. Same thing with embryo glue. There is good data, and we've reviewed it on the show, demonstrating that embryo glue will give you a better chance. So yeah, I'm not opposed to embryo glue. We don't use it just because it's expensive, and I'm not enough of a believer yet to think that we should be adding it in for every patient, but it's reasonable. You still need to put up the embryo math.
Great article. Thank you.
Oh, good. You're welcome. I love that article. I think that was a great thing for ASRM to put out. You know, most fertility specialists are pushing IVF. Everybody come for IVF. As you all know, I don't push people into anything, and I'm not a believer that everybody needs IVF. Sure, if you need IVF, we're going to do a better job than anyone. But do I think everybody needs IVF? No. Do I want most of you to get pregnant naturally? I want all of you to get pregnant naturally. So, you know, that's what's best for everyone. If we can achieve that, that's what we should be doing. So that's always our focus. Do the least amount possible for success. If we have to go all the way, we're going to go all the way 110 million%. But if we don't need to go all the way, we can achieve it with just dietary changes, vitamin supplementation, paying attention to the details, trying something simple like insemination. We'll try that for you if you're willing to try that.
And sometimes so for FET, what is the maximum my lining should be, and when should this be measured? At LH surge or ovulation? When should Clizane be started in a FET?
Okay, so your lining should be around 8 to 9 millimeters when you start your progesterone. You want to start aspirin, Clexane, all that stuff before you do your embryo transfer. All of that stuff is really important. And it should be measured frequently in terms of the lining thickness. So we measure it as you're developing your lining, when we start your progesterone, 3 days after we start your progesterone to make sure it's shrunken a little bit. And then obviously right before we do the embryo transfer. So we're like hyper vigilant. I think you missed one. Do I use steroid pills in my FET protocol?
That's the next one.
Well, that's the next one? Oh, okay, sorry.
Steroid.
I'm ahead of you. Do I use steroid pills? We do use steroid pills. Richard Scott, the, in my opinion, god of all things IVF, the man's like the smartest human being I've ever met. He said years and years and years ago, they did a study that showed that it was beneficial, and he never gave it up since then. So I've always used it as well. And for patients where we're concerned that there's an immune problem, we actually continue it. We switch from methylprednisolone to prednisone and keep them on the prednisone for most of the pregnancy, if not all of it.
Stress is causing for psoriasis.
Psoriasis?
Psoriasis?
Yeah.
Yeah, yes. So psoriasis flare. Will this affect my IVF retrieval and transfer? Would need to be on an immune protocol. What would you suggest?
So first of all, we don't want you stressed because we know it reduces your chances of success. Definitely don't do an embryo transfer if you're in the middle of a flare, because it definitely means your immune system is overactive. And depending on how bad your arthritis is and what type of arthritis it is, yes, I would definitely consider doing an immune protocol for you. Immune protocols really need to be customized. Immune protocols are not something where one shape fits everyone. So you really need to be in touch with us or with a reproductive immunologist, and they have to kind of walk you through it to explain it all to you.
Are high intensity cardio and light weightlifting discouraged while ovulating in 2-week wait?
High intensity cardio would be, light weights would be fine. We don't encourage HIIT training. Remember that if you're doing high intensity interval training or high intensity cardio, your blood flow is being redistributed to your muscles to help deliver oxygen there, and then to your skin to cool off your bloodstream, because you start generating more heat. So the reality is you're taking blood flow away from your uterus. That's definitely not a good idea.
Aside from the embryologist technique, what affects the percentage of fertilized mature eggs? Is it related to sperm quality?
Aside from the embryologist technique, what alters the number of mature eggs?
What affects the percentage of fertilized mature eggs? Is it
Fertilized mature eggs. I'm sorry. The sperm quality, for sure, the egg quality, and then the embryologist technique. So all of those are really important. So for example, you get premature or post-mature eggs, the fertilization is lower. If you get really bad sperm, the fertilization is lower. If your embryologist is using conventional IVF, your fertilization is lower. If your embryologist isn't good at ICSI, your fertilization rate is lower. There is a IVF program not far from us. I will leave them nameless out of respect, who have terrible ICSI success rates, and they always have. Horrible. My embryologist is the best I've ever seen. My previous embryologist thought that he was the best embryologist in the world. Our embryologist is better than he is. And I'm sure there are many amazing embryologists out there. So, we have incredibly high fertilization rates, success rates. Even blastulation rates here are very, very high. So it's unusually good in our lab. I still don't know why, other than that, I say prayers and my mom says prayers, and we're all 100 million% committed to excellence. But the reality is we just have a great lab, and our numbers are way better than any kind of average you see in any study.
Referring to the study you just reviewed in regards to caffeine, if you have PCOS, should caffeine be ceased since it's an inflammatory?
Caffeine isn't necessarily an inflammatory, so no. And I'm not aware of anything that says that caffeine is worse in PCO women than in anybody else. So if you want 1 cup of caffeine per day, that's fine. If you're, working a crazy job and you've gotten hooked on caffeine, that's a problem. So that's why I drink the green teas. I'll have caffeine only when I'm post-call or, on the weekends.
How much folic acid should I be taking?
A minimum of 400 micrograms. For those of you that want extra or want to cover all your bases, 4 or 5 milligrams.
I can't find DHEA from the pharmacy.
You can't find DHEA because it is a prescription. So we have to actually prescribe DHEA to you. And you have to get it compounded most of the time. It's not just freely available at all pharmacies. So if you need that and you're our patient, then you just get a hold of our office and we'll give you a prescription.
Correction to the previous.
I see that.
Yeah.
Endolaparoscopy in Windsor. I cannot do laparoscopy outside of Windsor unless you're paying for it in a private hospital setting. And that you can't do if you are doing it for a reason that would otherwise be covered from OHIP. So if you want to do it in Toronto, I'd have to refer you to one of my colleagues, which I'm totally happy to do. Problem is there aren't a lot of surgeons in Toronto that I trust. The guys that are good or the ladies that are good take a long time to get into. So that's where the timing comes from.
Is it possible to conceive with 0% morphology sperm? I sort of-
They asked us that.
Yeah,
Yep.
okay.
We answered the 0% morphology sperm question.
I've been reading that micro-injecting a patient's platelet-rich plasma can help with thickening the uterine lining in patients that have difficulty getting their lining to the ideal thickness. Have you heard of this? And is this a possibility at VRC?
It is a possibility. We've done it. It didn't work well in the one patient that I've done it in. We have another patient that's coming soon. It's not something we do frequently, but there are studies that support the fact that it can thicken the lining 1 to 2 millimeters. So that's definitely something we would be happy to look at. It's not so much a micro injection. It's actually a big load of the stuff, but we fill your uterus with it. And we actually turn it into aliquots, and I freeze the others and then have you come back so you don't have to pay a fortune each time.
Hey, Dr. Vickery, what are your thoughts on a natural FET at the age of 37 with one embryo left?
There's nothing wrong with the natural FET. It's perfectly reasonable. We talk about this on the show all the time. There are studies which show natural FET is better, and there are studies which show stimulated FET is better. And then there are many that show it's basically the same. I think overall, the data supports that they're basically the same. So if you feel less stressed by a natural one, do a natural one. There's nothing wrong with that. I still think you need supplements. And we do what we do based on all the science of what we do. And I mean, our success rates are spectacular, but you don't have to do it our way. Excuse me.
901.
Yeah, I went blabbering on for quite a bit. Check that out, man. My resting heart rate's only 58 beats per minute in the middle of a show. Look at that. All right, go ahead.
What dosage?
Are you good for a few more minutes? He's always good. Big round of applause for Tarek. Ibrahim Strategies Group, best guy ever. I love this guy. All right.
What dosage and how often take baby aspirin?
81 milligrams every day.
Easy. Sir, please. What?
Should I look at that?
Okay. Someone's spamming you for a shout out. Okay.
Oh, okay.
Do you monitor a low FHR closer in early pregnancy?
Early pregnancy frequently has lower heart rates. So we would bring you back frequently, yes. But it is frequently low, especially if you look really, really early. If you're checking at 5 weeks and 5 days, the fetal heart rate's often slow. So we don't panic about those. If it's normal by the time you're 6.5 weeks, you're probably fine.
You know, this question, they think it's a silly question, but I think it's an excellent question.
Okay.
This may seem like a silly question, but heated seats, back and bottoms after an FET, safe or not?
No, they probably emit electromagnetic radiation, so stay away from that.
Electromagnetic radiation.
Yeah. Heating blankets that are electric emit electromagnetic radiation, so you can't use them in pregnancy. I stumped Tarek, something he finally didn't know.
Well, I was surprised with that answer.
Yeah, no heated seats. Stay off of those.
Would you rather transfer a day 5 3BB or a day 6 4BB?
A day 5 3BB, because it'll probably become a 4 and 5 within a couple hours.
What transfer protocol would you recommend for a patient with PCOS who may also have endo?
Lupron and letrozole for 3 months, then extend the letrozole. The rest of it would be basically our protocol. NAC and inositol, coenzyme Q10, melatonin, baby aspirin, the antibiotics, the probiotics, monitor the thickness of the lining. Don't use any estrogen if you can avoid it. Wait for the lining to thicken. You hit 8 or 9 millimeters, start vaginal and injectable progesterone. Do 5 days if it's a day 5, do 6 days if it's a day 6. Very, very careful embryo transfer. Arguably intralipids and steroids if you have endo. If you're not sure that you have endo, don't bother.
How so recreational drugs affect sperm quality if you are taking HCG plus FSH due to past TRT?
I think they mean how do. Recreational drugs are terrible for your sperm, have nothing to do with HCG and FSH. It kills your sperm quality. It destroys the sperm DNA fragmentation. It's very damaging to your sperm performance. You cannot use drugs and try and make babies. It just simply doesn't work. And for all those people that think that marijuana is safe, there's a very, very good article in the New England Journal of Medicine that references a very important study where they looked at 50-year-olds, men and women, who were marijuana users versus non-users, and measured by CT scan, which is super accurate, their brain volume. The brain volume of marijuana users is smaller than the brain volume of non-users. It literally melts your brain. There's no part of marijuana that's safe. It's a cancer risk. It can be a carcinogen. It has very damaging neurological impact on you. It can impact a baby. It damages sperm DNA fragmentation. It's at least a 250% increase in your risk of miscarriage, even if it's the guy that's using it. So the fact that you're taking HCG and FSH because of previous testosterone therapy has nothing to do with the negative impact of marijuana. You're still going to get a negative impact. You're not going to undo that by taking vitamins. You're not going to undo it with HCG and FSH.
Dr. V, you always use steroid. Do you always use? I got it. Dr. V, do you always use steroid pills in your FET protocol?
We answered that one.
You let me go on that?
Well, I was waiting for you to finish.
My God, what did you do? What would be an indication of possible immune issues? Is multiple failed FETs enough to suspect a possible immune issue?
Yeah, for sure. That's enough to suspect an immune issue. Oh my God, I'm tearing from that. Multiple failed FETs would definitely be one. Hyperactive immune system. You get great big welts anytime you get a bug bite or a mosquito bite. You're never sick, or you frequently have rashes, joint inflammations. There's a history of any kind of autoimmune condition. All of those things would be like red flags for us.
Also, can I drink a can of Pepsi after an FET? I know it has caffeine, but I'm more worried about the sugar.
Yeah, absolutely not. Definitely not. That sugar load is insane. Terrible for you, huge amounts of inflammation. Stay away from all pop while you're doing TTC.
Do you accept patients that want to do IVF while still breastfeeding, provided their baby is past 12 months old and prolactin levels are back to normal range, as well as menstrual cycles back to normal?
Do I accept them? Sure. Will I encourage you to continue breastfeeding? No. Would I ever do an embryo transfer in someone that's still breastfeeding? No, because you're still going to have physiologically impacted prolactin levels. Even if it's measuring normal, your lining will not thicken properly. The human body is not designed to breastfeed and get pregnant at the same time. It's just physiologically not set up for that. So we would not do embryo transfers, but if you want to try other stuff, I'm happy to try whatever you want to try.
Regarding preparing for donor, so my doctor will give me the supplements, medications needed to support progesterone and/or estrogen for lining. And will the progesterone be the oil shots?
Your progesterone should be progesterone in oil and vaginal, both.
What antibiotics and probiotics do you recommend for FET?
You can use doxycycline. You can use a Z-Pak, which is probably the one we use most often. And then we use Flora, Flora, for our probiotic, but I mean, we don't have any specific preference for one or another. Any good probiotic will be fine. That's the one we use. I had a long discussion with our pharmacy. They said that was the one they thought was best, so we went with that one. But there's no evidence that one probiotic is better than another.
Sorry, but your clinic charged me $750 for PRP, not less, like you just mentioned.
For PRP, it's we're getting the PRP from another clinic, so the PRP part of it is $500, I think, is what they're charging us, And then we charge $250 for doing the treatments. So altogether, it's $750. That's actually correct.
I've been using a microwavable heating pack for my PIO pain. Is there a risk of heat being so close to my back?
No, because the microwave effect is over after you've microwaved it.
Can you tell me more about your live baby promise? How much?
Oh, well, it depends on what kind of live baby promise it is. So we have live baby guarantees for patients that are doing it with their own sperm and eggs. We have some with a donor. We have some with a surrogate. And then we have some that have a donor and a surrogate. So the prices are all different. And then we have one baby, two babies. And for same-sex men, we have one for each male. So you need to contact us for stuff like that. I can't go over that on the show, but the prices range anywhere from a low of about 23,000 all the way up to like 53,000, depending on which group you're falling into and what you want done.
I'm on.
The questions are endless tonight, eh?
Yeah, last one.
Oh, last one. All right, good.
So,
Until more people give us questions.
But
Yeah.
that's the second.
Okay.
I'm on progesterone suppositories for RPL.
Yeah.
Is that effective, or should I ask for PIO?
So we don't normally use PIO unless you've done IVF, and there is definitely no evidence that PIO will reduce the chances of recurrent pregnancy loss. Recurrent pregnancy loss really needs a diagnosis. We need to know why it's happening. We can't always find one, admittedly, but I'm a big advocate for trying your best to figure out what's wrong. So explore the infectious sources, the thromboembolic sources, the uterine abnormality sources, your hormones, the potential for infections inside your uterus with the fertility, your immune system being overactive, the genetics, your partner's habits. Is he a smoker? Are you a smoker? Drug use, alcohol, all of these things play a huge role. Even if he's none of those things, if he has high sperm DNA fragmentation, that can play a role. So before you actually start taking meds or jumping into programs or listening to the fertility dietitians or anything like that, make sure you figure out first what's actually wrong and address that. And all those other things can be super useful to add in, but they're frequently not going to fix the problem. We're done. Okay, well, thank you for joining us for this really cool episode of Fertility Fact or Fiction. I hope you guys enjoyed the show. We will definitely look forward to having all of you back again next week. And it does seem like there's some interesting data coming out on various topics again. So as the world slowly crawls back to normalcy, hopefully we'll have more information to share with you guys again next week. Have a great weekend. Have a great week. And we will see you again. We will probably be doing a show this weekend for our European viewers. So if you guys are seeing this tomorrow, at some point, we're probably going to do Saturday or Sunday show whenever Tarek's free for our Euro viewers. So, and then we'll probably be back again Monday too for you guys. So have a great night. I hope all is well. And Allison, I saw you just popped up there at the end. I look forward to seeing you guys soon. Take care. Bye.